Well, welcome. Thank you guys for joining us this evening. I think this presentation by Zach is going to be very informative and very interesting and be a great topic of conversation. So I'm very excited. My name is Claire Eagle, and I'm the Community Engagement Manager for Historic New Harmony. So my job really is to further connect the town of New Harmony and the University of Southern Indiana, which we are doing with this program. So Historic New Harmony is a unified program of the University of Southern Indiana and the Indiana State Museum and Historic Sites. And we're doing this series for several reasons. The first, of course, being the connection. But this was to be in conjunction with a museum on Main Street, Smithsonian exhibit called Crossroads, Rural Change in America. And unfortunately, COVID has canceled that for us. It was supposed to be in the summer and we were unable to do it. But we wanted to continue this series because these topics that we're talking about, especially the one we're talking about today, definitely still relate to kind of our current situation and how we move forward in this new socially distant world. So a few housekeeping things before I continue. Please keep yourself muted while Zach gives his presentation. If you have questions or comments as he presents that you'd like to share, you can share those with us in the chat, and we will get them to Zach during the Q&A session at the end of his presentation. This presentation is being recorded and will be posted to our Historic New Harmony playlist on the USI YouTube page in the next few days, definitely by Monday, depending on how long it takes us to get it up. So if you have to leave for any reason, or if you missed something or want to revisit, definitely be sure to check that out. So Dr. Zachary Ward is an assistant professor of health administration at the University of Southern Indiana. Zach's research focus includes burnout and rural healthcare issues. And most recently, he completed a stint at the American Board of Family Medicine as a visiting scholar, where he conducted a comparative study of rural and urban family physician burnout. So definitely pretty qualified for this conversation tonight. So without further ado, Zach, I'm going to stop sharing my screen and you have the floor.
All right. Well, thanks so much, Claire. Let me get this started here. And I am going to share my screen. And here would be it. So I'm going to click start. Can you see that okay? Great. Okay. Well, as Claire said, my name is Zach Ward, and I am an assistant professor of health administration at the University of Southern Indiana. Thanks for being with us tonight. I know when Claire and I originally spoke, we just shot a day off on the calendar and it happened to be election day. And we were communicating back and forth and said, well, maybe election day wouldn't be the best idea or the best day for this. Let's look at a different day. And I said, well, what about Thursday after election day? And well, here we are. So for those of you who are with us, thank you for your dedication. And we'll go ahead and get started so you can get back to TV and watch the results if you like to do that. And of course, my little PowerPoint clicker thing is not going to work. So let's do this. So kind of an overview of tonight. I'm going to kind of talk a little bit about the introduction of rural healthcare. Basically, we're going to talk about rural healthcare demographics and rural healthcare facts, rather, and the demographics that make up rural healthcare, or rural areas, rather. We're going to talk about a lot of the rural health negatives that we've heard in the news and that sort of thing. And then we're going to kind of spin it a little bit because there's a lot of positives that are going on in the rural healthcare area too. So while there's a lot of negatives out there, really want to focus tonight by focusing on positives of what's going on in rural America as far as rural healthcare goes. So this is kind of a collage, if you will, of the last, I guess, 18 months or so. Rural healthcare is a really hot topic in the United States. And as you can see, a lot of mainstream publications have picked up on this. We have the New Yorker, the New York Times, the Atlantic, NPR, the Washington Post. And kind of as what I mentioned earlier, there's a lot of negatives that we hear. We hear about rural hospital closures. We hear about the negative mortality rate and that sort of thing that's associated with healthcare, rural healthcare especially. So, and those are real, and we're going to talk about that a little bit tonight. So first, let's start off with some statistics about rural healthcare. Unfortunately, over the last 10 years or so, 174 rural hospitals have shuttered. I take that back, I read it wrong, sorry, but 174 have shuttered since 2005 and 132, so the vast majority, about 75% of those, have shuttered since 2010. Texas leads the way with 24 hospital closures and 21 since 2010. Actually, the state of Tennessee, which isn't too far away from us, is second on that list. Indiana's been a little bit more fortunate when it comes to rural healthcare and hospital closures in the rural areas. Indiana's only experienced 2 rural hospital closures since 2005. And when we look at the finances, that's always a big issue in healthcare. Since 2015, 36% of rural hospitals have reported negative operating budgets, meaning that they're in the red. And a hospital is just like any other business per se. You have to have a green margin on your finance books, and if you don't, you're in trouble. Rural healthcare, or rural America, is in desperate need of healthcare providers. Here's some really basic statistics, but if we look at physicians per 10,000 people, rural America is actually has about a third of what urban America has as far as physicians. And compared to urban dwellers, rural Americans are much more likely to die from heart disease, cancer, stroke, COPD, and unintentional injury. And to kind of explore some of these, a lot of it has to do with access to care. Also, too, intentional injuries. When we look at farming accidents that happen on the roadways and that sort of thing, being far from a trauma center definitely plays a role in that as well. What are the demographics of rural America? So let's talk about that for a minute. And these come from the Census Bureau, but rural areas constitute roughly 97% of the United States landmass, which is huge. But approximately 20% of America's population lives in rural areas. So 1 out of every 5 American citizens actually live in what we designate as a rural area. Demographically, rural Americans are much older. We look at about 17.5% of rural Americans are 65 years and older, whereas 13.8% of urban folks that live in urban areas are 65 and older. There's definitely an education lag too in rural America. College education is spelled out here, where 19% of rural Americans have a bachelor's degree or higher, compared to 33% of urban Americans who have a bachelor's degree or higher. Unfortunately, rural Americans are also poor. 16.1% of rural Americans live in poverty, compared to 12.6% of urban Americans. And also, unfortunately, rural Americans are much more likely to be disabled. We have about approximately 1/3 of rural Americans reported as being disabled. So let's look at rural hospitals for a little bit. So what do rural hospitals look like? I'll move this real quick here. This is kind of in my way. There we go. A lot of rural hospitals are what we would call critical access hospitals, or CAHs. So what is a critical, let's see here. There we go. What does a critical access hospital look like? So they have to be 25 beds or less, generally at least 35 miles away from the next nearest hospital. They have to have an emergency room, emergency department with 24/7 access. And this is kind of interesting, but for acute patients, they must maintain an annual average stay of 96 hours or less. So what that point is trying to get at is these hospitals, these rural critical access hospitals, cannot keep patients for very long times that sometimes you'd see in an urban hospital. What are the benefits of being a critical access hospital? There's a few. Cost-based reimbursements. So Medicare usually allows a little bit more for reimbursement than they would for an urban hospital, or rather a hospital that's not a critical access hospital. Also, for a critical access hospital, you're allowed to get some grants and other funding considerations that normally other hospitals are not eligible for. There's also some flexible staffing considerations with that as well. And an important note too, that while Medicare is managed by the federal government, Medicaid is usually managed by the states. And so because of that, certain states allow for different, there's some other state-to-state benefits that do vary due to Medicaid. So we're going to talk a little bit more about rural hospitals here. So what is causing rural hospitals to close? We kind of talked about that a little bit in the beginning of this presentation. So let's explore that. There's a funding issue. As we know, rural America has a very high Medicare and Medicaid population, and disabled patients are more likely to be covered by Medicare. And so here's the table of what that funding would look like. So this table I put together here kind of shows as a reference what Medicare would pay versus commercial insurance. So, for example, an inpatient hospital service where Medicare would pay $1, on average, a commercial insurance payer such as Anthem or Humana would pay $1.89. And you can kind of go through their outpatient, for an outpatient hospital service, it would actually be $2.64 and so forth on average. So you kind of start to see the discrepancy there, if that makes a little bit of sense, where Medicare, to be qualified for Medicare, you have to be either disabled or you're 65 and older. For Medicaid, Medicaid is usually for low income folks. And that's unfortunately, when we look at the demographics of rural America, that's kind of what we're looking at there. There's not a lot of employment opportunities, and the employment opportunities that are available in rural America, they don't pay competitive benefits that we may see in urban areas where they're competing for employees. So because of that, we see a lot of Medicare and Medicaid populations in rural America.
Exactly.
And unfortunately, because of that, our hospital finances do. Yes, ma'am.
I'm so sorry to interrupt. Can you define disabled as defined by Medicare?
Yeah, so disabled actually is where a person would actually have to say that they suffered an injury or they can no longer work. And then through that, there's a process, usually a legal process, where then the government would come in and say, you were correct, you can no longer work. And then from that point, you're afforded the benefits of being disabled. So it's a form of social insurance essentially, but very basic 30,000 foot view without getting too technical. That's what that is. And when you are deemed disabled, then you do qualify for Medicare.
Thank you.
Sure, absolutely. Go here to this. And I kind of alluded to this too, the local economy, fewer employers in rural areas eventually translates into less operating revenue for rural hospitals. Another issue too that occurs when a rural hospital closes is it's actually more difficult for an organization to relocate to a city where there's not a hospital. So it's almost a cyclical environment where there's not a lot of employment opportunities. It spins kind of to the financial aspect of it, with not a lot of commercial insurance patients and that sort of thing. The hospital closes, well, then the community really suffers because the likelihood of an employer coming to that community to pay benefits and desirable wages is really at a disadvantage at that point, because once again, employers like to see a hospital there in case there's a worksite injury or something like that. Also, too, another aspect that really that affected rural hospitals was regulations. Part of the Affordable Care Act was meaningful use, and we in healthcare heard a lot about that, and physicians had to attest that they're able to use health information technology in a meaningful way to document and to transfer in data to the insurance agencies and all of that. So when that happened, information technology is expensive, and hospitals will tell you. One hospital that I was familiar with in Kentucky, the academic center, just transitioned to Epic, which is an electronic medical record, and it cost the organization millions of dollars. So every patient room gets a computer, and of course there's the technology aspect, the hardware costs associated with that, but also too the software leases, paying the additional folks that you have to hire for the infrastructure to keep the technology going. So there's a lot of costs associated with the regulations that healthcare operates in today, and that's another aspect that it's really starting to sting a lot of rural hospitals. Want to talk about a few centric areas of rural healthcare that are really affected when, not only when a rural hospital closes, but are also just affected in general in rural areas. So I want to talk about a few areas. I have rural emergency and obstetrical care, but also want to talk about mental health care for a moment as well. We know emergency care, research suggests that mortality rates actually increase when EDs, emergency departments, have closed in rural areas. And often that's attributed to the fact that people have to travel further for emergency care. So, for example, in a rural community, perhaps there's a road, there's an accident rather on a road there in a rural community, rather than the ambulance service taking that patient then to the nearest emergency room, which may be 10, 15 minutes down the road. Now that patient has to travel over an hour away. So how do you do it? Do you do it by ground? Do you do it by air? Air has all kinds of issues. The visibility has to be well for a helicopter to fly, and all of those factors that kind of go into that calculus. So yeah, without emergency access or emergency care access, lives are definitely in jeopardy. Obstetrical care too. So OB units have been closing in rural hospitals for some time. And they've been doing that for a few reasons, mainly because it's very expensive to operate a mother-baby unit within a hospital. The neonatal coverage that has to be there, the obstetrical care that has to be there, the emergency care that has to be there in case something goes wrong for mom or baby. There's just so many factors that go into that. So a lot of hospitals have actually been closing their OB units before the hospital even closes, if the hospital closes. So what I did in here, just to kind of paint a picture to give you an idea, is I put the mortality rate, the infant mortality rate of a rural, of what it looks like in rural America, which is 6.55. In an urban area, it goes down a little bit, as we would kind of think. It goes to 5.44. But then I just put the country of Cuba as a comparison. The infant mortality rate is actually lower in Cuba than it is in the United States in general. So that definitely kind of illustrates kind of the starkness that we see with our infant mortality rates in the United States just in general. Talk a little bit about mental health too for just a second, because this is such a deep need in not only rural America, but America in general, but we're going to focus on rural America. As I mentioned here, there's a need for mental health professionals in suburban and urban areas. So you can imagine being a small hospital or a small health system trying to attract psychologists, psychiatrists, and those sorts of qualified professionals in an area where you're competing with urban centers all the time for those same professionals. We do know that unfortunately rural America has a higher suicide rate compared to urban areas. And as I kind of alluded to, it's just the access and the availability of those mental health practitioners is desperately needed in rural America. In the next slide, actually after that, but just to mention one more thing about mental health care. Mental health care is one of those areas too that we need to focus much more on rural America, only because of the fact that we're starting to see opioid prescription abuse and that sort of thing. There's a great book when I teach a seminar course called in our MHA, or Masters of Health Administration program, and in that course we read a book, Dopesick by Beth Macy, and it highlights the opioid epidemic that we've been seeing in rural America kind of explode over the last few years. So that's just another aspect, another need. It kind of highlights the reasons why we need mental health care in rural America. The next slide actually shows a video, and this video is actually done by the Wall Street Journal, but it highlights, it's about a 5-minute video, and it highlights the overwhelming need for maternal care and obstetrical care and baby care that we will see in rural America. So I'm going to go ahead and click this here.
A rural area is where I've always wanted to work. That was my dream. I wanted to be somewhere where I was needed and somewhere where I could make a difference.
Beautiful. Absolutely perfect. You are doing such an awesome job growing this little man.
There's no OB care out here. And for these ladies to get care, they would have to drive over an hour if I were not out here. And some of them just don't have the transportation to do that, the money to do that.
Maternity care is disappearing in much of rural America. This small hospital in Louisville, Georgia, is one of the few facilities within a 60-mile radius where women can receive prenatal care. But that's only if they can get to their appointments with midwife Linda Randolph, who comes just twice a week.
You know, some days we can have 12 scheduled and only have 6 show up, and other days we can have 12 scheduled and have 15 show up. Sometimes it can be frustrating. It's important to get prenatal care because there are so many things that can go wrong. And the only way for us to know that there's a problem is to have routine care.
The rate at which rural women die of pregnancy-related complications is 64% higher than in large cities. And Georgia has one of the highest maternal mortality rates in the country. 1/3 of the counties have no OB units at all. In Louisville, Linda Randolph can do basic prenatal checkups, but women must travel an hour to Augusta for anything that requires specialized equipment, such as diagnostic imaging, and to deliver. Without a car, being pregnant can be a logistical nightmare.
Transportation is our biggest issue, and it's kind of a 50-50. Some have cars, most don't. A lot of them carpool. I have several that walk. Some of them take Medicaid transportation. Part of the problem is it's such a large area that they're coming from outskirts and they're having to come from a distance. Some of them drive 45 minutes just to get here. Now, I know you're having trouble getting to Augusta to get that ultrasound and all. Is there anybody that you know of that can take you?
I could probably ask around, but you know, be hard. Just give me like 2 weeks.
2 weeks.
In rural area like this, you gotta get there how you get there.
In rural Georgia, a lot of the ladies don't get care outside of pregnancy. So there are other coexisting issues that a lot of them have. We see a lot of heart disease, a lot of diabetes, a lot of high blood pressure. And if those are left untreated, then ultimately mom could die. If something goes wrong with your pregnancy or with your delivery, you can have a matter of minutes. I mean, minutes. And if you are an hour away from a hospital, as opposed to 5 minutes away from a hospital, that makes a big difference.
The number of rural labor and delivery services has dropped nationally by 15% from 2004 to 2014. In Georgia alone, 35 OB units have closed in the last 2 decades, 1/3 of those in just the last 5 years. That's partly due to a declining rural population and a poor economy. As people get sicker and medical costs increase, hospitals aren't able to sustain themselves.
Some of the largest difficulties, number one, is reimbursement. Not all of our patients have insurance. Many of them are self-pay. And if they don't have money, it's very difficult to collect money from them. Another one is access to qualified personnel. So being in a rural community, not everybody wants to live in rural Georgia. It's hard for us to pay competitively with, say, Augusta. You really have to have a passion for rural healthcare.
A lot of people are straying away from the rural areas. And I understand that. It's not for everybody. But there are ladies that live out here that need care. They need somebody that wants to do it, is not just doing it for a job. And if I can be that.
It wouldn't be a good presentation if you didn't have some kind of error with the video. So the video
Person that steps in their life and says, you are somebody that's worth any money that I could ever be paid.
There we go. So just to talk about that for a little bit, that video does a fantastic job, probably better than I could ever do, of talking about some of the issues, particularly around maternal care in rural America. I work for a health system here in Kentucky, for quite some time, and one of the rural hospitals that was associated with the organization that I worked at, there was a hospital somewhat close to there. It was the only population center for about 80 miles, 90 miles, and when they stopped delivering babies, there was a big hardship not put on just that city, but all the little communities where that one small hospital was that would send their moms over there to have a baby. So at that time, my wife was pregnant with our children too when that was going on. So it kind of really made me think, wow, I can only imagine having to drive that far for those kinds of services. So your heart definitely goes out to those folks there. To look at rural healthcare workforce for just a minute, because I think we definitely have to talk about that for just a little bit. Rural America, if you look at the rural, or rather primary care, it's about 40 primary care physicians per 100,000, as opposed to 53 per 100,000. Specialists, if you need a specialist in rural America, you're out of luck, is basically what this statistic is telling you, because while there's 30 per 100,000 in rural America, there's 263. And of course, those take into account the major academic medical centers and that sort of thing. A little bit of hope there, though, is we're starting to see advanced clinicians starting to fill those gaps, particularly in primary care. Nurse practitioners and physician assistants, particularly. And what we've begun to see too, particularly with respect to the nurse practitioners, their scope of practice in many states has actually expanded. Historically, there were agreements where there were state mandates, rather, that nurse practitioners needed a physician to collaborate with, and some states have really, I don't want to say completely gotten rid of that, but in some states, there's been this definite push to change that law where nurse practitioners can actually practice autonomously. So there's some hope there that we're starting to see more nurse practitioners fill those, and physicians assistants for that matter, fill the gap for primary care. And just before we start to pivot and look at some of the positives, here are some maps that I wanted to share of health profession shortage areas. And where we're particularly interested in for tonight are the green areas. And so if we look over here, this is for primary care. The dark green areas highlight the most need. So that's greater than 15. There's this algorithm that goes into scoring these counties, which is kind of complex, but essentially the higher the number, the more the need. So we look at primary care and we see, like, for example, the state of Nebraska is doing pretty good there. It's light green. But if we look over here, though, we see a lot of dark areas for mental health. And this kind of underscores the point I made earlier. There's such a need for mental health care in the United States, but particularly in rural areas, because you can definitely tell by the dark green there. So we're going to pivot a little bit. I don't want to be all gloom and doom. It does us no good to be that way, but there's some reasons to be hopeful in rural America too, particularly when it comes to healthcare. So this couldn't be a healthcare conversation without talking about COVID. This is one of the few times I don't have to wear a mask and I can breathe, and it feels kind of good. So, but we're all wearing masks now, which is a good thing. But COVID-19 has really exposed a few things in rural healthcare. I mean, rural healthcare or rural hospitals are already strapped for cash. And then March, April, May came around. Hospitals shut down all elective procedures. All non-emergent office visits were canceled. So your regular routine checkups were canceled and all of that. So then what that created is a void of cash flow for hospitals. So if you recall to those first few slides, there was a huge amount of rural hospitals that are already operating in the negative. So then you go 2 months, 3 months without cash flow. That's a serious problem. And so when we look at the statistics a little bit again, 15 rural hospitals have closed this year alone. Once again, it's tied to money. And what we've seen, I've talked to some of my friends that do hospital supply chain management and that sort of thing. PPE equipment. the price of that equipment has rose dramatically. A friend of mine that does this business, there's various vendors that he deals with. He's talking about just a simple N95 mask. The price has gone up so much more. I can't recall the exact price, but just, I think it was just, 300-400 times what or 10 times what he was paying for, rather. So those are serious issues that hospitals, particularly rural hospitals that have zero budget or a very, very slim margin, they have to be concerned with. So, but there is a little bit of hope. And I have a video here that's going to talk specifically about PPE in rural healthcare.
I spent the last 10 years as a rural hospital CEO in 2 different rural Kansas communities and have fallen in love with rural people. And I'm more convinced than ever that they have a seat at the health equity table. Hospitals are facing formidable challenges amidst this pandemic, with access to personal protective equipment, supplies, resources, finances, and with rural hospitals, it's particularly challenging.
Before the COVID-19 pandemic, rural hospitals in their communities were struggling for survival. What COVID-19 has done is it's essentially taken us into highlighting or putting a spotlight on the fractures that already existed within rural communities in terms of their healthcare delivery.
Nursing is really cool in the regards that you can provide a lot of different services, but rural really connects to my heart because I get to take care of the community that has taken care of me.
This community and the patients we serve are very important to me. They're my friends, they're my family, they're my neighbors, they're the people I see at the grocery store. And I think it's really important for people to remember that rural hospitals play a very essential role in care for these people.
You think, hey, we're in a rural place or we're just isolated or the virus can't come here and affect us like it's affected other places. But if you look at our area a little bit closer, we are surrounded by meatpacking plants. The meatpacking plants can't close. America needs to eat. And with that comes all kinds of things that make social distancing more difficult, not less difficult.
The meatpacking plant is one of our major resources as jobs. And so it's a multicultural community. We have 73 languages. We have Somalian, Hispanics, we have Filipinos. We all come together as a community.
One of the most significant challenges for rural hospitals during COVID is their access to personal protective equipment, or PPE. And rural communities find themselves at the end of the traditional supply line, which generally favors orders of 1.5 million as opposed to 150, right? And a rural community may need 150 masks to keep their staff safe, but those 150 masks they really need.
Lincoln Community Hospital is the only facility within a 75-mile radius. If I can't have PPE and I can't keep my staff and my patients safe, I can't be here and I can't provide that level of care to people within that big of an area.
If we don't have enough PPE, then we are exposed.
Now we're seeing, in the wake of COVID-19, rural populations facing the problem of accessing supplies, such as personal protective equipment, exactly what Hearts for Heroes is trying to produce in terms of an outcome.
Heart for Heroes is hacking the supply chain. It is taking the last and making them, if not first, at least in the middle of the line. It is engaging Project Cure to procure or locate supplies that can go to rural or underserved communities. It is engaging Angel Flight and the networks across the nation of thousands of volunteer pilots who donate their plane and their gas and their time to deliver these shipments of PPE out to the nearest landing strip near these rural hospitals at no charge. And the people that receive them are some of the most appreciative.
We've received a donation of PPE. We went out to the airport to pick it up. And actually, as we saw the plane land, I'll get teary even talking about it because it was just very tearful, very heartwarming to know that people were donating that to us and that, we were able to give that stuff to our nurses. It was a wonderful experience.
I'm so thankful for Heart for Heroes for thinking of specifically of rural communities like ours. I don't know how many different ways to say thank you, but we can't say thank you enough for that.
This connection is going to be taking rural providers around the country, presenting the need, and then connecting that with the resources that are out there. And that includes Heart for Heroes, which is the sourcing mechanism. And then Angel Flight is another partner that could be useful in getting those supplies from where they are to where they need to be.
This is not a short-term problem. This is a long-term problem. We are going to see PPE shortages for the next 12 to 24 months, really until we have either a vaccine or herd immunity. We're going to see shortages of PPE. And this support is not just needed for a month or two. This is needed for years. And this will determine, in many ways, the outcome of rural healthcare in the United States.
So that video right there kind of highlights at least some of the positives where we're coming together as a community, and we're starting, while some of us have always seen rural America as where we grew up, like me, there's also folks that, if you live in a large city, you just kind of think about, well, the world's just here. It's not the small places in America. But when we see people come together for incredible needs such as PPE, that's so difficult to find. And so if you're a rural hospital, you don't have a big operating budget to begin with. So when it comes to sitting at the table and trying to bargain for those supplies, you've got an insurmountable hill to climb. So when you see Project Cure come around and Civil Air Patrol, they're in Colorado doing what they're doing, it's more than amazing. So that makes me feel a little bit hopeful that, the pandemic has brought some changes. Not to get off on a tangent, but we were at church the other day and we went to go drop our kids off because church had just opened up again. And the line to go get our children was stretched all the way back after church. And one of the gentlemen that works there in the nursery said, we just have one drop off and one pickup area and this is it. I said, after COVID, I'm sure we're even going to design our buildings differently. We're going to have many entry and exit points just to facilitate this. So hopefully this has been a positive that we see with all the negative that COVID has brought us. Hopefully we've seen this, we continue to see this togetherness, if you will, in rural America. Another thing I'd like to talk about is the recruitment of rural medical providers. And we kind of talked about the statistics, and that rural America now lags behind urban America in many of those statistics. There's been great efforts focusing on recruitment, but also the retention of rural providers. And this is something, I'll admit, I worked in a health system for 13 years, did a little bit of everything from medical staff issues to building a family medicine residency program. I will tell you right now that so many health systems really kind of lag a little bit when it comes to retention. You spend a lot of money, you go to a lot of recruitment fairs to recruit physicians, but what are you doing to keep them there? And that's something that I think a lot of hospitals are starting to ask themselves, but rural hospitals in particular really need to ask themselves that. So in talking with some rural hospital CEOs that are pretty innovative, there's one gentleman in particular, you saw him in the previous video, Benjamin Anderson. I spoke to him at great length a few months ago. He's been in the news a lot, particularly when he was a hospital CEO in Kansas. He made a lot of news in Politico. He was published in Politico, CBS Sunday Morning, about how he's able to keep family physicians in rural Kansas. And he said, he talked about student loan forgiveness. Well, I will tell you, a lot of hospitals do that. Salary, you got to pay them a comparable salary. Well, many hospitals will try to pay above that salary line, the average salary to recruit physicians. But he started saying a few things to me that really made me think, wow, I haven't heard this before. One of those was more time off. So when he was a CEO at a hospital, he said that, we gave everybody 12 weeks of vacation. And that's huge because the hospitals where I came from, you needed the physician there to generate revenue. So to give them more time off seemed a little bit more counterintuitive, in a few ways. But he had a great point. If you bring physicians in, you give them time off to do what they want to do, they're much more likely to stay because they're happy. And so that really got me thinking, wow, we focus so much on paying salaries. Perhaps we should look a little bit at maybe more time off. And then he also talked about having an equitable call schedule. I don't care what whatever business you work in, there's always this intended or this implicit hierarchy, if you will. The person who's been there for 12 years gets seniority, so they don't have to do the grunt work, if you will. The new person has to do the grunt work. But he said, no, look, I really push for an equitable call schedule. What I mean by that is that I don't care if you've been here for 20 years, you've been here for 2 weeks. You're going to take 4 days on, 3 days off. And so that really meant, that really got me thinking too, wow, this is a great idea. And so he's been out evangelizing this, if you will. And it's really caught on with a lot of rural medical centers. And they're beginning to see some success with that. The other point here I want to talk about for a little bit is physician training, residency programs. So I think So there was a study in the Annals of Family Medicine, I want to say in 2013, that talked about family physicians, and I actually did not put the number in here for some, but 56% of family physicians practice within 100 miles of the residency location. So where they went to residency, to back up for a second, to be a physician in the United States and to be licensed and all of that, you not only have to go to medical school, but you also then have to do a residency. Family medicine is 3 years. If you want to be a neurosurgeon, that's 7 years. But what we're beginning to see, though, is a lot of rural areas are trying to increase building residency programs. And that's actually my last job before I transitioned to academics. So it's tough to do that. It's tough to build a residency program, but we're starting to see rural areas really kind of band together to build residency programs because they know there's a lot of value in full spectrum family medicine. And I think that's actually my next point. Yeah. So when we look at full spectrum family medicine, not only are these people following you just for general medicine, they're doing true cradle to grave experience. So they're doing deliveries, they're doing newborn visits, they're taking care of adolescent medicine and pediatric medicine and adult medicine, but they're also taking care of geriatric medicine, right? So those elderly folks. And there's a lot of value in full spectrum family medicine, because if we look at how much a salary is for, say, an obstetrician or a pediatrician even, it's a little bit higher. It's a lot higher for an obstetrician. So if a full spectrum family physician is able to come in and do the job a little cheaper. And I hate to say it that way because it sounds like I'm really degrading that. I'm not at all. But if they're able to come in and do that job and they really want to be in a rural area, it's a win-win for everyone. So just to conclude here, rural healthcare, as I see, it's kind of at a crossroads. Hospitals are closing at a very high rate. And that divide is becoming more apparent. But there's also a lot of hope, as I kind of mentioned. One thing that is really starting to show promise, another kind of, I guess, blessing, if you will, that we've seen during COVID is the hope for telemedicine. We've begun to see that internal physicians, family physicians are able to follow their patients now and do checkups just like we're doing this conference right now. And there's a little bit of an issue because rural America needs more broadband access. There was a story a few years ago in College Station, Texas, which I want to say is the home of Texas A&M University. If you just went like 5 miles outside of the university in any direction, there is no broadband internet. And it just kind of underscores the need for broadband internet in rural America. But we're starting to see that number go up. It's going up slowly, and we need it to go higher. But there is hope for telemedicine, particularly when we talk about not only primary care, but also mental health. Also, too, we've heard that millennials, if you will, have a very they're coming out of school, and when they come out of their training, they have a mission mindset. Millennials are tied to brands that have a mission, if you will. Their spending habits tend to follow that. So that's encouraging, because now we're starting to see these millennials coming out of school and stuff, and perhaps there's hope that they want to go and continue that mission, and perhaps that be in rural America. And then lastly, too, as I've kind of alluded to, COVID has exposed the need to take care of each other. I know here in where I live at, my neighborhood, there's neighbors who we've lived here for 5 years who have never spoken to. And after COVID hit, we'd be out walking the dog or walking the kids and the dog, and they would just come out, "Hey, how's it going?" And that was really assuring. And just to know the fact that we kind of have this sense of community and this sense of togetherness that COVID has brought us, I think, unfortunately, because there's been so many negatives that come out of COVID, I think that's hopefully one of the other blessings that's come out of COVID, is that we need to take care of each other, and hopefully this really goes to benefit rural America. So here's a few links I have if you're interested in rural healthcare. The Rural Health Info Hub is just great. It's full of information of anything related to rural healthcare that you can imagine. You can find it there. So if that's an interest to you, definitely check that out. The National Rural Health Association is another great example of advocates of rural healthcare, and they have a website there packed full of statistics and that sort of thing. There's also the Federal Office for Rural Healthcare Policy. If you're kind of a geek like me, you probably enjoy that too. Lastly, and I promise I'm not getting paid to plug this, but Where It Hurts podcast. I came across this last week. It's actually a regional public radio station in St. Louis has put these podcast series together. And this is a 5-part, maybe a 6-part series now. I think they may even come out with more. So the number there may be incorrect. But in the first few episodes, they've explored Fort Scott, Kansas, and the hospital closing there and the precipitous effect that has had on the community. It's done very beautifully, where you're able to go in, the reporter goes in and talks with all of the various citizens, interviews hospital administrators, former hospital administrators, talks to the nuns who used to operate the hospital, talks to the city manager, talks to the citizens, and you get this comprehensive, almost view of what rural healthcare is like in a city or when a hospital closes. And at the end of the series, you're like, wow, I feel like I live there. I feel like I know these people. It's done great. I highly recommend that you check that out. And there's also a few other podcasts too, but that one really, particularly if you're interested in rural healthcare, that's one that I would definitely check out. And that's what I've got for you tonight. So again, thanks. I know some of us would probably be rather watching election returns or something like that tonight, but I'm glad you're here tonight with us. And if you have any questions, I'll be glad to answer them any way I can.
Thank you, Zach. That was very, very interesting. And once again, I'll echo his. If you guys have any questions, feel free to put them in the chat. I know we've had a few come up already. So I will kind of just get right into it with one that I had. You mentioned that some states are looking to change their laws so that nurse practitioners can practice autonomously. Are those states rural states that are looking to change those laws?
Sure. So I know of particularly my home state of Kentucky that's happened. So a few years ago, Kentucky required that nurse practitioners work under family physician or a physician in general, and certain hospitals still require that collaborative agreement. But the law, as I interpret it, now I'm not an expert in that law, but the way that I interpret it and several around me, as a nurse practitioner, you can actually quote unquote hang your shingle in Kentucky, just like an independent physician could. But we're also seeing, and to that point about scope of practice expanding and everything like that, another perfect example of that is optometrists in Kentucky. And I think in other rural states, their scope has expanded as well. So optometrists are not physicians. They, unlike an ophthalmologist, which is an MD or a DO, an optometrist is a OD. But so an ophthalmologist can do surgery. They do cataract removals and those sorts of things, LASIK, we've all heard of that. But optometrists in Kentucky could not do that. But there was a law passed 2 years ago, I want to say, that actually expanded the scope of practice for optometrists. And I had a conversation with an optometrist right after that happened. And he kind of went back to the nurse practitioner perspective. And he said, look, we know that folks need eye care in this state, LASIK, cataract removals, and that sort of thing, but ophthalmologists aren't available. So we lobbied the state and we got our scope of practice expanded. Now, granted, there's training that goes with that and everything else, but just to kind of underscore that point too, particularly kind of pointing to those rural areas where that scope of practice is beginning to expand.
And then you mentioned the critical access hospitals. So I understood what you defined them as. Can you give an example of one in this area that might help people better understand exactly what you meant by a critical access hospital?
Sure. So Perry County in Tell City is a critical access hospital. They're capped at 25 beds. Ohio County, Kentucky, which is one county south of Davis County, where Owensboro is located, is a critical access hospital. I actually, it's funny. I made a map of all these about 12 months ago, and I have it in my office. But and then there's one in Illinois, El Dorado Hospital. I want to say Fairfield. Mm-hmm. It's in the tri-state area. I know that, but if you probably didn't ask me, I would tell you the name of it because I would have known it. But I want to say that the hospital's name is perhaps El Dorado, or that for some reason El Dorado is coming to mind.
All right, so now I'm gonna head over to the chat and see what we have. So you kind of had at the beginning of your presentation the ratio of disabled, those defined as disabled in the rural areas compared to urban areas. And this question is why are there as many disabled people in the rural areas as kind of you noted? You said it was higher, it wasn't typical or
Yeah, there's a few theories behind that. And so I will preface this by saying I'm not a sociologist, but there is also this train of thought out there that employment's hard in rural areas. We know it's hard to get gainful employment in rural areas. When it is difficult to find a job and provide for not only yourself and your family, you look for other means to provide. Mm-hmm. And so, for example, that could be, perhaps somebody got a back injury working in a coal mine, let's say. We work in jobs. I think some of us do, where we're fortunate we work in office jobs. So if I were to hurt my back, I go get some physical therapy, but I'm able to go back to work. If I work in a coal mine and I hurt my back, that's a little bit different. That's very labor intensive kind of work. So there's that aspect, right? The manual, arduous labor. But also, too, there's this other train of thought out there, too, that if you can't find a job after so long, you go without employment, then you find other suitable means to provide for your family and provide for yourself. And maybe that is you look for perhaps, you may find that you have a chronic injury that you may qualify for disability. So there's also been a lot of fraud associated with this too. In Eastern Kentucky, for example, there's an attorney there that it was like this made for TV kind of movie. The narrative was where he had a judge in his back pocket. He paid the judge. There was all of these disability claims that happened to be approved by this judge. And then something happened there and then it all exploded. He flew down to South America. So there is some corruption there as well. His last name was Khan, believe it or not, which was very fitting. But there was billboards all over the state for this. And so you would see them. And it was like an FBI actual billboard that the FBI put up looking for this guy. But there's also some fraud associated with it too. And I'm not trying to say that it's all fraud. It's definitely not. There's just so many factors that go into that.
All right. This is a question from Dan. So the economy, the coronavirus pandemic, and racial injustice have emerged as top issues for voters in the 2020 presidential election. According to NBC News exit polls, not healthcare. Do you think that by calling out COVID-19 as a key driver, is that the same as healthcare, or was that different?
That's a good point. And you're right. We've heard a lot about the economy. We've heard a lot about racial injustice. We've heard a lot about COVID. But this has been probably the first presidential race I can recall where healthcare has not been front and center. It's been discussed, right? But we haven't heard about it as much. And you wonder, is it being drowned out by the other pressing issues? I mean, look, I personally think in this country we have several pressing issues. Healthcare is not it's both acute and chronic. And what I mean by that is we know we have a healthcare problem in this country. We know that 1 out of every $5 that we spend in this country is on healthcare. That blows every other country out of the water. And we look at how healthy we are as a country, we're no healthier due to all that spending. We're actually probably, some could make the argument that we're more sick because of all of that. We're actually doing ourselves harm rather than good. Respect the economy. The economy is always a front and pressing issue. The racial injustice has been a little bit unique in the fact that it's been real front and center so close to the election. And COVID has been there too, because let's face it, the last time we had a pandemic, I don't think, maybe our grandparents or great-grandparents had to deal with it. I mean, it's over 100 years ago. So when we're looking at all of this, healthcare is one of those things where it's unfortunate that we're not talking about it as much as we are right now, because there's coming a point very soon, in my opinion, where healthcare is just unsustainable right now at the current cost. You have people that are working, jobs with a deductible, a family deductible of $5,400, $5,600 on the average income for a household. I want to say the median income for a home in the United States or a household is like $50,000. So if you have a deductible of $5,400, that's more than 10% of your annual income that you've got to spend on healthcare out of pocket before you get any, big break, minus the deductions that you get with insurance. So it's going to be interesting to see how this is going to play out. It really is. But I think that it's one of those things that it's kind of being drowned out right now, if that makes sense. Mm-hmm. But it's unfortunate that it is, because as important as everything else that we've discussed is healthcare should be up there too in that same category.
So not to go off on a tangent or anything, but I know something that I've seen a lot in regards to social injustice is how healthcare plays into that. Do you think that that the fact that it plays into that social injustice and the fight that's currently going on for that and everything, do you think that'll bring healthcare back to the forefront as far as kind of putting it into that same issue?
Yeah, no, I think that's a great question, because we know that if you're African American, you have a higher chance of dying of COVID than you do if you're white. I mean, those statistics are being discussed right now. It's really a shame, and this is, once again, I'm going to get off on a tangent probably as well, but it's really a shame that in this country we have that discussion. And what I mean by that is that we have to worry about, what race we are, as opposed to healthcare just being available for everyone. We shouldn't have to worry about those kinds of statistics. If you're sick, you get healthcare. But we know that's not true. And as unfortunate as it is, like for example, we look at the infant mortality rate in rural America. And there's another stat out there, and I forget now, but racial minority women who give birth are much more likely to die than white women in the United States. To me, that's unbelievable. I mean, we think about healthcare being available for all, but that's really not the case. And to your point, yeah, in a way, this is all interwoven. It's not being displayed in a way that I think that I think that it could be, perhaps. But certainly, yes, I think that it's all interwoven and it's all interconnected. And if anything, yeah, we definitely need to be having those conversations more than we are.
All right, we have another one. So what are your thoughts on immigrant physicians who often work for some time in rural America as part of their visa agreement? Do they make a significant dent in the physician shortage, and is turning to immigrant physicians a valid approach to the issue?
Yeah, that's a good question. So I want to say it's like an HB1 visa waiver that you're able to come in. I knew of a physician that So the way I understood the agreement, that the physician, the immigrant physician, had to go and work for 5 years in a rural area. And this is an example that I know of. And to backtrack a little bit, this physician completed residency in the United States. So in order to come to the United States and be a practicing physician, you have to complete a residency in the United States, either the United States or Canada. So if you did a residency in England in the National Health Service, it won't cut it for the United States. You have to do a residency in the United States. So, or Canada for that. Canada, the Canadian residency is also accepted. But so what a lot of rural hospitals will do is they'll offer the visa waiver. Hey, you come here and work for like 5 years, and then you're permanently here. And I get kind of confused on the different names of the visas and all of that. But I knew of a case where a physician went to residency. I want to say in Louisville or Lexington, Kentucky, and then he went to go work in a rural hospital for 5 years. And then once his 5-year commitment was up, he said, okay, thank you. I did a residency in internal medicine, and I want to be a pulmonologist, critical care physician. So I'm going to go do a fellowship in pulmonology and critical care. So here's how that played out. That hospital had a physician for 5 years. But then after that, after his 5-year obligatory window was up, then he went on to do his fellowship. Look, I think at the end of the day, you got to try something. You definitely do. And, you're not going to keep everybody. And sometimes you don't, because by the time you sign a physician, they get in there, you have such a need for a physician in a rural community, for example, then you realize they're really not that great of a physician, right? Their quality may not be well, they may not get along. And that's a whole nother conversation about how to deal with toxic people in healthcare, right? But at the end of the day, perhaps maybe we need to be in a mode where we're looking at bridges and bringing immigrant physicians in for those visa waivers for however long that window is. At the end of the day, is it sustainable for that long term? Maybe it depends on your definition of long term, right? If it's a year and they stay there for 5 years, that's a victory. But if you're able to get a flow of physicians in there that are doing great work, sure, maybe that bridge actually works. But also too, as you begin to look at this, maybe you have to kind of switch your mentality what sustainable is and look at from 30 years to maybe 5-year increments. And if that's the case, then sure, that's a success.
All right. And this last question is from Dan. Are you yourself advocating for more rural hospitals?
Yeah, no, I think that's a great question. I think what we have to think about is that hospitals themselves are extremely costly to maintain. Not only are we talking about the emergency department, we're talking about the operating rooms, we're talking about mother-baby, we're talking about all the other ancillary services like endoscopy and all of that goes into it. And then we have the aspect, okay, you're going to stay in a hospital for a few days while you're sick. I think, we're at this crossroads, kind of like I mentioned earlier. We have to come up with a viable option. And emergency care, I think we've kind of all understood that emergency care is really needed in rural America. Perhaps it's kind of a hybrid where we get rid of the traditional notion of what a hospital is, and maybe we have this facility, just say hypothetically, that offers emergency care, but also offers specialty care, and then too, same-day surgery. So we know, for example, if you need your gallbladder taken out, you can go there, get it done, then go home and recover. But if you need something a little bit more complex, something that's a little bit more urgent, you either don't go to that facility, or if it's an emergent issue, you go to that facility, you're stabilized, and then you're transported to an area where there's a higher level of care. And I think that makes sense for a few reasons, but if anything from tonight, you kind of get the idea that this costs a lot of money. Healthcare costs a lot of money. And if we can get away from, okay, look, that person has to have their feet in the bed for 48 hours before we discharge them, we got to get away from that, because that's not working for rural America. So let's get away from the mentality of, okay, you're sick, you need to go to the hospital. If you're sick and you need to go to the hospital, maybe we go get emergent care first, and then we're transferred to a facility where that care is offered. But for specialty care, if you need to follow up with a neurologist, you need to follow up with a pediatrician or whatever it may be that's, for you or your family, having this hybrid kind of facility there that offers emergency care, same-day surgery, endoscopy, for colonoscopies, mammograms, all of those preventative services. I think that kind of makes more sense than having a traditional hospital where they offer everything, plus you can be admitted for issues as well.
So here's another question that just came in. So here in Southern Indiana, we are seeing our bigger hospitals acquiring smaller hospitals, such as Deaconess partnering with Methodist of Henderson and buying out Gibson County Hospital. Should we be turning to those big hospitals to take on the financial and logistical parts of rural healthcare coverage?
That's a great question too, and I think that's kind of what we're seeing play out, and not just here in Southwest Indiana. We're seeing it all out, all over the country. Intermountain Healthcare is a perfect case study of that. Intermountain Healthcare started out in Provo, Utah, back in 1970, and now they operate a slew of hospitals in the Intermountain West. We're seeing that for a few reasons, mainly because smaller hospitals were financially vulnerable. So we're seeking larger organizations such as Deaconess or Ascension Health or whoever it may be that come in and assume operations of those facilities. I mean, also too, it's a little bit of relief too for some rural hospitals when a larger institution comes in, because they have the operational capabilities more so than a rural hospital to operate in a climate. They have easier access, if you will, to experts. They have a bigger financial team. They have the infrastructure, the health information technology that's so expensive. So it's, you see this loss of autonomy when the community hospital may sell out, for lack of better terms, to a larger health system. But honestly, it probably creates some kind of relief because, one, the hospital doesn't close. And that's a huge relief. That is a huge relief when you know that if you need emergency care, the emergency room is still going to be open in your small town. There's the pride issue that comes into play as well. I mean, many hospital boards are ferociously independent and they like to be independent. So when an organization comes in and says, look, we're going to operate this, well, then there goes a little sense of pride. And I completely understand that. But when we look at how this is playing out throughout the country, I think that, it may become more of the norm because healthcare has always been, financially complex, but it's more financially complex today than it was yesterday. I mean, it's just constantly getting more and more and more complex. So when we're starting to see smaller hospitals, surrender their operations to a larger organization to come in and kind of operate it, I mean, yeah, I think it's twofold. One, there's this bit of pride loss that occurs, but also too, for an organization to kind of come in and take over a small hospital, there's got to be this sense of like, well, at least we're keeping our hospital. We're keeping care in the community. And that's an important aspect to consider.
All right. Well, that is the end of our questions. Thank you so much, Zach, for being with us today. I think that was a wonderful presentation and an even better question portion. I think I learned a lot. So thank you for being here. I'm just gonna share my screen just for kind of my conclusion here.
Zach, thank you for your time tonight. Thank you all for your questions and being a part of this evening's conversation.
Sure, thank you.
So I just kind of want to give my closing here. We do have a few more presentations for the Crossroads series coming up. We have one on Thursday, November 19th with Kevin McKelvey, and he is going to be presenting Arts Community in Place, a collaborative workshop. And then we have Lisa Below's presentation that was rescheduled from a few weeks ago, We Never Leave Home, which is kind of about writing and literature and how it relates to rural life. And then finally, I did want to share with you that on Tuesday, November 17th, we are presenting a new virtual program called the Harmonist Connection. And this is really special because we have the 3 sites of the Harmony Society coming together in a virtual manner to kind of talk about our sites and what connects us. And that is on November 17th at 6 p.m. So definitely join us for those. And then finally, stay connected. We have a monthly e-newsletter, which you can find at usi.edu/inharmony. You can sign up from there. There's also a pinned post at the top of our Facebook page that has sign up information as well. The November edition will be going out probably in the next week, and you don't want to miss it. It's going to be a great edition. And then, of course, stay connected with us on social media. We're on Facebook, Instagram, as well as Twitter. And then if you are interested more about the Crossroads Speaker Series, you can go to usi.edu/Crossroads Speakers, not only to see what we have upcoming, but we also have links to all of our previous presentations if you missed one. So definitely check those out. So once again, thank you guys for joining us this evening. I know that election results might have stopped some of you from joining us, or you might have had to pop in and out, but we do appreciate it. And of course, this will be on YouTube, so if you missed anything, you can see it as well. So thank you again, Zach. We really appreciate it, and I hope all of you have a great night.